This is the Beats Working Show. We're on a mission to redeem work, the word, the place, and the way. I'm your host, Mark Wright. Join us because getting paid to practice beats working to get paid. Let's talk a little bit more about those drugs so that people have a better framework. Buprenorphine and methadone. How are those drugs used to treat people with substance use disorder?
Yeah, so both of those medications are used in my clinical setting to treat opioid use disorder. I guess to take a step back about what opioid use disorder is, the DSM-5, so the manual that tells us how to make these diagnoses has a bunch of criteria. And I think the two ones that we are most familiar with are tolerance and withdrawal. So tolerance meaning that you need to have more and more of something to have the same effect, and withdrawal meaning if you abruptly stop something, do you develop symptoms? And that can definitely happen with opioids that are prescribed or non-prescribed. But it can also happen with lots of other medications that we use and other substances, but medications in particular that we use clinically every day. I can think of like certain blood pressure medications that if you stop them abruptly, you can cause withdrawal in some instances. You need more and more to have the same effect. So there's these kind of physiologic things that can happen based on opioid use and other substances. But really what makes a substance use disorder an opioid use disorder is when your use starts impacting kind of the psychosocial things in your life. So those things can be your relationships, your work, your other life, your other activities that you enjoy. Do you start using in risky situations? Do you use more than you would like or for longer periods than you like? So it's really these when other kind of these social things start being affected by your opioid use that it becomes an opioid use disorder. So to make the criteria of opioid use disorder, you have to have two or more of those criteria, and they can't just be the tolerance and withdrawal.
Wow.
So, yeah.
So when you prescribe these drugs, I don't want to get too technical because I'm not able to get too technical. But as I understand it, these drugs attach to some of the receptors that the narcotic normally would attach to, and it sort of soothes the system or makes the system feel okay and not needing the drug. Is that how they work?
Oh my gosh, yeah, you like hit the nail on the head. You
Oh,
could
good.
definitely talk about this. You could come talk to patients about this. The way these receptors work, if you can imagine kind of an XY diagram, opioids, like full opioid agonists mean like opioids that bind fully to those receptors. On the Y-axis, kind of bind fully to the receptor and have a full opioid effect. And then shorter acting opioids, like say heroin, back in the days where heroin was still readily available, they're short acting. So they bind fully to those opioid receptors, have a full effect on that Y-axis, but be short acting. So on the X-axis of time, there'd be a peak and a trough. With fentanyl, we know that like the amount of time that fentanyl actually has an impact is much shorter. So it's like even peakier. So it like peaks and then troughs like very much more narrow. So if you can imagine that on that XY graph, the way the medications we treat opioids can also be mapped out. So for example, with methadone, has a full opioid effect, so it binds fully just like heroin and fentanyl does, but it lasts for a long period of time. So instead of having those peaks and troughs, plateaus, it kind of modulates, so they kind of smooths that out. So if you can imagine, like someone who's using heroin maybe has to be like redosed like every couple of hours or so, just because of how short acting it is. With fentanyl, I've talked to patients, sometimes it can be like every 2 hours they need a redose because of how peaky it is. But with methadone, you have that full opioid effect and it lasts for a long period of time. So you don't have to have that frequent redosing. So a medication like methadone binds fully to those opioid receptors and can help with cravings and withdrawal. Remember, like those symptoms that are needed for the diagnosis of opioid use disorder. In super high doses, like with like any other full opioid agonist, like heroin, fentanyl, and methadone, and really high doses, it can cause some of the negative side effects like sedation, respiratory depression, especially when combined with other sedating medications. So for those reasons and some other reasons based on the pharmacology of methadone, often folks need to kind of be started on lower doses of methadone and build up over time. And so that's kind of the physiologic reasons why methadone is a little bit difficult to get on. And then there's all these like bureaucratic, legislative, like actually federally mandated reasons why that there are lots of obstacles and barriers for patients to actually get started on methadone, because methadone can only be dispensed from an opioid treatment program, a particular clinic. At at this moment, and it's been this way for the last 30 or 40 years. And it's really tightly regulated, and there are lots of rules that one has to follow. So that can make it difficult for folks to get on. And then I'll just quickly mention buprenorphine, which is my favorite medication of all time, but it's a partial opioid agonist. And you can remember that XY graph again, that buprenorphine kind of binds kind of halfway up that graph. It binds that receptor in a different way than those full opioid agonists. And by binding in a different way, there's actually a ceiling effect. So, and what that means is that it helps with cravings and withdrawal, like the treatment of opioid use disorder, but it doesn't have some of those negative side effects like respiratory depression and sedation, and can be safer with other sedating medications. So buprenorphine is something that's also not as tightly regulated. So folks like in an outpatient clinic in the emergency department can dispense it, meaning like giving someone that medicine in front of them, and also prescribe them long prescriptions for it. There are some complications that fentanyl has created for us in starting folks on both methadone and buprenorphine, so that the landscape has definitely changed. But buprenorphine in particular, in my clinical setting in the emergency department, is our go-to. And there's some really exciting and novel things that are happening with buprenorphine to help get that medication out to people.
Well, let's talk about the barriers a little bit later in our discussion, but I wanted to talk about fentanyl since you just raised that. I spent a little time on the DEA website last night, and correct me if I'm wrong, this is what was posted there. Fentanyl is now the leading cause of death for Americans between the ages of 18 and 45. And in the calendar year of 2023, the DEA seized more than 77 million fentanyl pills and nearly 12,000 pounds of powdered fentanyl. That's enough fentanyl to kill the entire U.S. population. That was seized in 1 year. The testing of fentanyl now is showing that it's even more potent. And some of the DEA testing labs are showing that 7 in 10 pills that they test contain potentially deadly doses of fentanyl. And that's an increase from 4 out of 10 just 2 years earlier. In your mind, Callan, I guess we know that fentanyl is scary, but when you start to look at some of these stats, it's unbelievable what this drug is capable of doing, and you see the receiving end of it. I would just love your perspective on fentanyl right now, and what do we need to know as just average everyday citizens when it comes to this drug?
Yeah, and those are terrifying statistics. And I think I would add to that, as we're rattling off numbers, is I think in 2023, which is the number that the year that you had mentioned, the seizure data, I think more than 100,000 people died of drug overdoses in the US, I believe. And in King County, so where we're currently sitting, where Seattle is, there were 1,300 people who died last year from overdose. So we definitely, like thinking about the upstream and downstream effects of things, we definitely see these patients in the emergency department all the time, and first responders see them out in the field. So patients who have died from an overdose and overdose survivors. So if you think about the folks who are dying from overdose, there's a much larger population of people who survive overdose, and thinking about how to best serve them. I think when I think about fentanyl, I go back to how fentanyl is different from other opioids. I think you gave some striking examples of just the potency of the pills that are being manufactured and distributed, and the amount of seizures. I think some of the things that I also think about are, well, 3 things in particular, actually. So one being that it's super short acting. And I mentioned this before, and I think this is important to note, because I think with folks who are previously using heroin or other short but longer acting opioids like oxycodone or Oxycontin, those kinds of things, though folks wouldn't have to dose so often and just to feel well. So if we can think of another XY graph, like often I think something that I think the public may already know, but I think something to emphasize is that this kind of euphoria that Yeah, like I think the feeling of being high often wears off very quickly. So patients who are using opioids, like there may be some euphoria associated with their use initially, but as soon as their use becomes disordered, like all those things that I was talking about, they're really just using opioids to like get back to feeling well and not feeling withdrawal anymore. So if you could imagine a patient who's using fentanyl and it's wearing off in their bloodstream so quickly that they have to redose so quickly, and every time they use, the drug supply is toxic and may be a fatal dose. It's like playing Russian roulette. Like every time they redose, it can be a very dangerous situation if they're not using in kind of safe ways, like using test doses, using with someone else, having naloxone available to them, having safer use supplies, like kind of all the harm reduction things are available to them. So that's one thing, is that's short acting. Two is that it's super potent. And I don't want to belabor this, but I think you talked about this. It's just much more potent in smaller doses. And then the third thing is that it's lipophilic, which is a fancy word. And I'm not a fancy doctor, but it's just like it hangs out in our fatty tissue and muscle very strongly. And why that's important is that it sticks around for a long period of time. And even though it's short acting in the blood, it sticks around in our fatty tissue and muscle. And that actually makes it complicated to get started on the medication buprenorphine, because buprenorphine, in addition to like all its amazing attributes, is it's super potent and super strong. So it binds to those opioid receptors and actually knocks off other opioids. So the way that we often ask patients to get started on buprenorphine is to actually abstain or to not use any opioids for a prolonged period of time. And historically with heroin, that would be like 8 to 12 hours. With fentanyl, we've been asking patients more like 24 to 36 hours. If you've ever encountered someone who's experiencing opioid withdrawal, that's an incredible ask to try to support that person through that process, especially if they're dealing with any other type of social dynamic, like they're experiencing homelessness, don't have access to clean water, those kinds of things. And I just bring that up because when we think about the innovations of how we get people started on a medication like buprenorphine, we really have to think about the pharmacology of fentanyl and how it's really changed the game.